You've been there. You made the appointment weeks ago. You rearranged your day. You showed up on time, maybe even a few minutes early. And then you waited. 10 minutes? 20? 30? The front desk is calm. Nobody seems alarmed. And you start to wonder, does my doctor just not respect my time? Here's what almost no one tells you. By the time you walk through that door, your doctor may already be an hour behind, through absolutely no fault of their own. And the reasons why have very little to do with time management and everything to do with a system that was never designed for the reality of human health. Let's get into it. Every medical practice runs on a scheduling template. Think of it like a blueprint for the day. 15 minutes for a follow-up, 30 minutes for a new patient, 20 minutes for a procedure check. Neat rows, clean blocks, everything accounted for. There's just one problem. The template is built on averages, and in medicine, average is just fiction. Who builds the template? Usually a practice manager, a scheduling manager, or a physician leader, working from historical data on how long appointments typically take. They're not being careless. They're making the best estimate they can with the information they have. But they're also under real pressure. A schedule that's too spread out means fewer patients seen. And in today's healthcare reimbursement environment, volume is a financial lifeline. Practices aren't padding their schedules for leisure. They're filling them because they have to. So the 15-minute follow-up slot gets built. It works fine, right up until the patient in that slot hasn't come back for a routine check. They've come back with new symptoms, new concerns, a family member full of questions, or a condition that changed since the last visit. The template didn't account for that. It never could, because the template plans for the average patient, and the average patient doesn't exist. And then, before a single patient has even arrived, something else can quietly unravel the day. Staffing. A medical assistant calls in sick. There's no replacement ready. The remaining staff absorbs the workload, rooming patients, taking vitals, managing intake, answering phones, with one fewer set of hands. Each task takes a little longer. Each room turns a little slower. On a schedule with no margin, every extra minute compounds. In a vascular practice, the stakes are even higher. A vascular technologist, the specialist who performs the diagnostic ultrasound before a patient ever sees the provider, has a family emergency and can't come in. Now the practice has a choice. Run all those ultrasounds through whoever is available, which stretches the imaging timeline significantly, or begin calling patients to reschedule. Either way, the day is already behind before 8 a.m. This isn't a staffing management failure. Healthcare has faced persistent workforce shortages across nearly every clinical role, and smaller practices often have no bench depth to draw from. One absence, one emergency, and the schedule absorbs the impact, and so do the patients waiting in it. This is the part that most patients have never thought about, and once you understand it, it changes everything. Let me walk you through a real scenario from a vascular and vein practice, the kind of practice where a routine follow-up appointment isn't just a quick check-in. It includes a diagnostic ultrasound of the leg before the patient ever sits down with a provider. A patient is scheduled for 9 a.m. Routine follow-up. The template allots 15 minutes. But first, they're 5 minutes late. That might not sound like much, and most clinics understand. Life happens. Traffic is real. Finding a parking space in an overfull lot on a busy morning isn't a character flaw. It's Tuesday. The challenge is that most practices have a late arrival policy for exactly this reason. If a patient arrives too late, they may be asked to reschedule, not to be punitive, but because working them in an already tight schedule creates a downstream problem for everyone else. but rescheduling carries its own cost. For patients managing a vascular condition, a delayed appointment isn't just an inconvenience. It can mean a delayed diagnosis, delayed treatment, or a worried patient going another several weeks without answers. So the clinical team makes a judgment call. They work the patient in, and now the first domino has fallen. The ultrasound begins, and this is where routine ends. What the imaging shows isn't what anyone expected. Something has changed since the last visit. The provider now needs to spend time reviewing the new findings, comparing them to prior images, thinking through what this means for the patient's care plan. A conversation that was supposed to take 15 minutes now takes 45, not because anyone is inefficient, because the condition demanded it. There may be a referral to coordinate, another specialist who needs to be looped in. There may be a procedure that now needs to be scheduled, prescriptions to write, and to explain carefully enough that the patient actually understands what they're taking and why. By the time that patient leaves, it's 10:05 a.m. The next patient scheduled at 9:15 has been waiting 50 minutes. And now the cascade is in motion. The 9:30 patient is behind. The 10 o'clock patient is behind. The provider is trying to make up time without cutting corners, which is an almost impossible balance. By noon, they may be a full hour behind, not because they lost track of time, because healthcare is built on human variability, and the schedule was not. Here's something most patients don't realize. The appointment doesn't end when you leave the room. For every patient a physician sees, there is documentation that has to happen. Clinical notes, diagnosis codes, orders for labs, imaging, or procedures, referral letters, prior authorization requests, medication records. In a procedural specialty like vascular or interventional medicine, that burden is considerably heavier than a primary care visit. A procedure generates documentation before it happens, during it, and after. Every step has to be captured, both because it's the standard of care and because reimbursement depends on it. Electronic health record systems were supposed to make this faster. In many cases, they've done the opposite. Physicians now navigate complex interfaces that were often designed around billing compliance rather than clinical efficiencies. Templates that don't match what actually happened. Required fields that demand answers to questions that weren't relevant to the visit. So what do providers do? They document in the margins of the day. While you're in the room, your provider may be typing, not ignoring you, documenting in real time so the note doesn't pile up. Between patients, in the brief windows while the next room is being prepared, documentation happens. And then, after the last patient of the day, when most people have gone home, many providers are still at their desks. It even has a name in medicine: pajama time. Charting that happens after hours when the house is quiet and the inbox is finally manageable. This isn't a story about poor work-life balance. It's a story about documentation burden that was added on top of patient care, and time that was never added to the schedule to account for it. Let's talk about something that has probably happened to you. You arrive on time, you sign in, you settle into your seat, and then 10, maybe 15 minutes later, someone walks in after you. They sign in, and within 5 minutes, their name is called, and they disappear through the door, and you're still sitting there. It feels like a mistake, or worse, like you've been overlooked. That frustration is completely understandable. From where you're sitting, the math doesn't add up. But here's what the waiting room doesn't show you. What's happening on the other side of that door isn't one line. It's multiple lanes, often running completely independently of each other. In a vascular or interventional practice, for example, the same facility might be running a follow-up clinic with ultrasounds on one side, a minor procedure schedule on another, and a surgical suite operating on a third timeline entirely. The provider seeing routine follow-ups might be 45 minutes behind. The provider performing in-office procedures might be exactly on schedule. The patient who walked in after you and got called back immediately, they may be seeing a completely different provider, or they may be there for a type of visit, a quick post-procedure check, a single diagnostic test that runs on a separate workflow with its own room, its own staff, its own clock. From the waiting room, it all looks like one system. It isn't. It's several systems sharing a lobby. This is one of the places where better communication from practices can make a real difference. Something we'll come back to in a moment. But the underlying reality isn't unfairness. It's complexity that's invisible from the outside. There is one more variable the template never accounts for: urgency. Every practice, no matter how tightly scheduled, has to make room for the patient who calls at 8 a.m. with sudden swelling in their leg, or the referring physician who sends over a patient that morning with a finding that can't wait 2 weeks, or the patient who had a procedure yesterday and is calling with a concern today. These patients can't be told to wait for an opening next Thursday. Clinically, ethically, it's not possible. So they get worked in, which means someone else waits a little longer, which means the cascade grows. Think about this from the front desk perspective for a moment. They are fielding calls from patients who are scared, managing a schedule that is already full, and trying to make decisions in real time about whose need is most urgent. It is a job that requires clinical intuition, emotional intelligence, and nerves of steel, often without formal clinical training. When you're sitting in the waiting room and you don't understand why it's taking so long, there may be a patient in the back whose situation was simply more immediate than anyone anticipated when the day began. Not because your care matters less, because that's what healthcare actually looks like on the ground. So what can actually be done about this? Good practice management teams think about this constantly, and there are real strategies, but they all come with trade-offs. Buffer slots are one of the most effective tools. Instead of booking every slot consecutively, you intentionally leave gaps in the schedule. Breathing room that absorbs the variability when a complex patient runs long. If the day goes smoothly, those slots can be used for urgent add-ons. If it doesn't, they keep the cascade from compounding. Appointment type sorting is another lever. Not all follow-ups are equal. A patient returning after a minor procedure has a very different appointment profile than a patient being evaluated for a new vascular condition. Sorting these into different slot lengths and being disciplined about it helps the schedule reflect reality more accurately. Both of these strategies work, and both of them push back against a very real financial constraint. Every buffer slot is revenue that isn't being generated. Every appointment type sort requires scheduling staff to make more complex judgment calls when booking. In a healthcare environment where margins are thin and volumes drive sustainability, building a more forgiving schedule is genuinely harder than it sounds. Which brings us to one of the most misunderstood practices in scheduling: overbooking. In many practices, the schedule intentionally holds more appointments than can theoretically be seen, because experience has shown that a predictable percentage of patients simply won't show up. No call, no cancellation. An empty slot that could have gone to someone who needed it. From the practices side, overbooking is a calculated hedge. No-shows are a real and costly problem, clinically and financially. A slot that goes unfilled is care that wasn't delivered and revenue that wasn't recovered. Overbooking is an attempt to keep the schedule productive, despite that unpredictability. From the patient side, it's the reason you sometimes arrive on time and wait 40 minutes before being called back, because the practice built in an assumption the someone wouldn't show and everyone did. Neither side is wrong. The practice is trying to stay viable. The patient is trying to be respected. The tension between those two things is real, and there's no scheduling formula that resolves it cleanly. This is the tension that practice administrators and physician leaders navigate every day. The schedule that works best for patient experience is often the schedule that is hardest to sustain financially. There's no clean answer. There's just the ongoing work of trying to get it closer to the right balance. But there is one thing that costs nothing and changes everything: communication. One of the most consistent frustrations patients report isn't that they just waited. It's that nobody told them they were going to wait. They sat there for 20 minutes, 40 minutes, without a single word from anyone at the front desk. No acknowledgement, no update, no indication that anyone knew they were still there. That silence is where frustration becomes resentment. The fix isn't complicated, but it does require intention. When a schedule starts running behind, a proactive practice calls ahead, reaching patients who haven't left home yet to let them know there's a delay, giving them the choice to arrive later or come prepared to wait. That one phone call can change the entire emotional experience of that appointment before the patient ever walks through the door. For patients already in the waiting room, the standard should be simple. No one sits unacknowledged. A brief check-in. Hey, Sally, we're running about 15 minutes behind. We haven't forgotten you. Takes 10 seconds and resets the entire dynamic. It signals that the person behind the desk sees them as a human being, not a number in a queue. This matters more than practices often realize. Waiting rooms aren't always designed to help. In some layouts, patients are seated facing away from the desk entirely. Rows of chairs pointed towards a television or a wall with no natural sightline to the staff. In those spaces, the sense of invisibility is built into the architecture. It takes deliberate effort to overcome it. And that effort has to flow in both directions. Front desk staff can only communicate what they know. When the back office, the clinical team, the rooming staff, the providers, keeps the front desk informed about where the schedule actually stands, the front can keep the patient informed. When the internal communication breaks down, the patient is the one who feels it. A waiting room where people feel seen, updated, and respected is a fundamentally different experience than one where they feel forgotten, even if the wait time is identical. So, the next time you're sitting in a waiting room, watching the clock, wondering where your doctor is, know this: they didn't forget about you. They didn't lose track of time. They are most likely with another patient who needed more than the schedule allowed, or they're finishing the documentation from the patient before that, or they've just absorbed an urgent situation that had to be prioritized. The wait is real. The frustration is valid. And understanding why it happens doesn't make it less inconvenient, but it does change what it means. Your provider is not running behind because they're disorganized. They're running behind because they are doing exactly what you would want them to do when it's your turn in that room, giving the care the moment requires without watching the clock. The system that created this problem is complex. The people working inside it are doing their best. In episode 3, we're going to pull back the curtain on something you've definitely noticed but probably never fully understood. What actually happens after your appointment? The billing, the coding, the claims process, and why a visit that lasted 20 minutes can take months to fully resolve. We'll see you then.